day, doc, and welcome to Fort Med. Today, we shall be discussing acute abdomen. As a way of introduction, acute abdomen is severe abdominal pain that lasts more than 6 hours and is caused by some condition of surgical importance. It is a sudden spontaneous abdominal condition that may require immediate surgical intervention. Acute abdomen is usually non-traumatic. It is not a specific disease entity also, but may arise from various conditions. Good clinical acumen and investigative modalities are required to establish the diagnosis. The key to successful treatment of a patient with acute abdomen is to determine the specific cause. Urgent and timely surgical intervention will thus improve the outcome of that patient. Looking at the anatomic consideration of the abdomen, the abdominal organ types are solid, hollow, and major vessels. Clinical features will relate to the type of organ affected. The etiology of acute abdomen is numerous. It can occur from inflammatory conditions such as acute appendicitis, acute cholecystitis, acute sapingitis. Acute abdomen can result from intestinal obstruction, from incarcerated hernias, volvulus, obstructing tumor, or mesenteric vascular occlusions. Acute abdomen can also occur from perforated oloviscos, as seen in perforated typhoid ileitis. Acute abdomen can result from hemorrhage, ruptured viscera, ruptured ectopic pregnancy, or ruptured aortic aneurysm. Acute abdomen can also occur from ureteric causes. Medical causes of acute abdomen can also include diabetic ketoacidosis, pyelonephritis, acute gastritis. The dilemma a surgeon has in dealing with a patient with acute abdomen is, should I operate and find out that there is no problem? Should I operate and find out that there is no surgical problem while exposing the patient to anesthetic risk and post-operative complication, or I should avoid operation for a surgical condition which may result in catastrophic effects of the disease? Diagnosing acute abdomen, it requires taking a detailed history. Abdominal pain is invariably present in all conditions, so the site of the pain may suggest the organ involved. We need to characterize the pain. We need to know the onset of the pain. Is it of sudden onset or gradual onset, which can be in inflammatory condition? The severity of the pain should be assessed, and progression of the pain should be known. What are the aggravating and relieving factors of the pain, and does the pain radiate to any part of the abdomen? There's the need to make inquiry about gastrointestinal symptoms, nausea, vomiting, if of any episode, constipation, diarrhea, jaundice, passage of dark stool. Drug history is also important. Does the patient use NSAID, or does the patient abuse alcohol? There's need to know past surgical history of the patient. We need to know, does the patient has other surgical conditions such as hernia, or has the patient been treated operatively in the past? Also, we need to make inquiry about constitutional symptoms such as fever, chills, headache, and for women, there's a need to know the gynecological and sexual history of such patients. Having taken the history of this patient, we need to examine this patient appropriately. On general examination, the patient will be in painful distress, they may appear febrile, pale and dehydrated. Their pulse will be high, greater than 100 beats per minute. They may have hypotension and they may also appear tachypneic. On abdominal examination, inspecting the abdomen, you will find little or no movement. The abdomen may be distended with visible peristalsis. You may find surgical scars and you may find hernias. Signs to watch out on abdomen on inspection will include Collins sign, which is periumbilical ecchymosis, great tunnel sign that can occur in retroperitoneal hemorrhage. There will be tenderness on palpation. Signs that can be elicited will include pointing signs, swell signs, Murphy sign. On percussion, there will be no shifting dullness if there is hemorrhage, and there will be diminished or absent bowel sound when you auscultate. So also, doctor, you need to remember to examine the vagina, the scrotum, and the rectum of these patients.